Good afternoon. I'm Enrico Ascher, the executive co-chair of the VEITHsymposium, and I am really very honored and very happy to be here with the leaders in limb salvage, in the evolution of limb salvage and the future of limb salvage in the United States. I am here surrounded by great guys who have taught me and taught vascular surgeons around the world what are the standards for limb salvage, what the research being done, and what's basically the future, as I mentioned. To my right, I have Dr. Michael Conte, who is the PI of the study. Dr. Joseph Mills on the left, he is the Scientific Advisory Board, the chair. And Rick Powell on my right, also my far right, is the head of the Data Safety Monitoring Board. Today, we're talking about a game changer, a potential game changer that can help basically millions of people. Because despite all our endovascular and open surgery attempts, the number of amputations, major amputations, at least in the United States, is actually increasing. So the idea of having a stem cell product that can help save those limbs that have no option is just magnificent. So I'm very excited about hearing from some of the manager of this program what they think about it. And let me start with one question to the PI, Dr. Conchi, and I'm going to ask him what are the key strengths and some of the limitations of the BGC 101 trial.
Well, thanks, Enrico. BGC 101 was designed as a phase 1/2 trial of this novel autologous cell therapy product for patients with no option CLTI. And some of the strengths of the trial are that it was designed to be blinded and randomized. Patients received their own cell therapy product or a placebo by injections in the limb. These are all patients with pretty advanced CLTI that met strict hemodynamic criteria. Some of the other strengths of the trial is that many other endpoints besides amputation were captured, including pain scores, quality of life, and hemodynamic assessments over time that allow us to look for important effects on patients, but also mechanisms of activity of the study. As far as limitations, it was not designed to be a statistically significant powered trial. It's a study of 40 patients to show us if there's positive signs. And so it's a small scale trial, but the findings are actually quite positive.
That's great. This is an amazing study. But so tell me a little bit more about the patient selection. You mean if you show someone that's experienced in limb salvage, show him these patients, you think that we'll consider them a no option for sure?
So, all the patients had to have at least Wi-Fi grade 2 ischemia. So that's pretty severe ischemia. Toe pressure is less than 40. We also did not want to include patients with very, very extensive tissue loss. So there were patients with, reasonable degrees of tissue loss. We had a group that could review these cases and make sure that they fit the inclusion and exclusion properly so that it was fairly standardized. And experienced investigators, as well as the board, could review the angiograms and agree that there was no conventional option for revascularization.
That's pretty clear. Thank you very much. So, Dr. Powell, can you provide me some context on the spectrum of patients in this study as compared to other prior studies of biologics or even lymph flow?
Yeah, thanks, Enrico. I've been working on biologic trials for about 23 years and have run trials for different gene therapies and cell therapies. These particular patients are patients who had a lot of associated comorbidities and in general had pretty significant tissue loss. I'll say that throughout the 23 years, this is the first time I've seen a trial where there's been a positive result based on amputation-free survival and not a surrogate endpoint, that we've always been looking for as a way to sort of look for efficacy. I mean, I think the thing that maybe surprised me and is probably the most important is that we actually see a difference in amputation-free survival.
This is really fascinating results. So let's talk about some of the biology of this product.
Yeah, so within the limits of what I can say, that the amazing thing to me in this study was the logistics, because the blood had to be drawn on the patients, and it was sent to Dr. Porat's group, and the endothelial cell progenitor cells and stem cell progenitors were prepared, and then the drug was sent back to the study site, and that was all accomplished quite expeditiously, which is, if you want to treat these patients, you need to be able to do it on a schedule. So that was, the logistics of that amazed me. And then to follow up on what Dr. Powell just said, it wasn't powered to show a difference, but it does in amputation-free survival. So there was a 2-to-1 enrollment. There were 2 that got the therapy versus 1 with placebo. But there were, the only death was in the placebo group. And there were 2 amputations, I think, in the BGC group and 4 in the placebo group, even though the BCG group was twice as large. So the amputation-free survival turned out to be significant. So the limitations, again, it's a small study, but it certainly calls for a much bigger study to look at this. The second thing that they did, which I thought was really interesting, was we used both Rutherford and Wi-Fi. So all patients had to have Rutherford 4 or 5. So they have either rest pain or tissue loss. But then, since Rutherford 5 is such a broad group, I think a lot of these studies in the past have focused on patients that were too far gone for any therapy like this to work. So the wounds were grade 1 wounds. So heel wounds, large heel wounds, massive soft tissue defects, those weren't included. But that gives us a way to kind of focus this therapy, like what patient is going to likely be served best by this. So it was an interesting study.
Fantastic. I have 2 questions. One is, it seems that the company is in Israel. And Israel is not close to New Jersey or New York. How does it work? You draw the blood of the patient, the blood sample, you ship it to Israel, and it has to come back. What's the time limit that you have to actually eject those stem cells on the patient?
It was rapid. I mean, the turnaround was, 36 hours? Is that right?
I can tell you we did some
was
test
1
runs
day.
to San Francisco before we started, just to ensure that the product would meet the specifications with the turnaround from Israel to San Francisco, and it was fine. So
Perfect.
they've managed to process this pretty rapidly with their protocol.
And all you have to do is inject back on patient's blood or local? You inject anything locally?
It's local injection into the leg.
Any ultrasound guidance, and what exactly inject?
It's IM injections.
IM injections. Yeah. How many injections? 1, 2,
30 injections.
30 injections in the leg that's ischemic, of course.
Half a ml each.
And how long do you wait until you see the result?
I mean, this trial was designed to have a single application. And it's one of the important things we're looking at in the data. We can see some signs, both in terms of hemodynamic improvement and wound changes, maybe within a couple of months. I don't know that we know exactly what the kinetics are, or that we could rule out the need for additional treatments based just on this one study.
Any difference in the patient's presentation, like rest pain versus ulcerations or gangrene? Any difference? Early difference? Any perception, Rick?
Yeah, we haven't looked at, tissue loss versus rest pain, but most of the patients had tissue loss. We have looked at diabetics to see if there's a difference. In the results with regards to amputation-free survival are sustained both for diabetics and non-diabetics.
Sounds like, as I said in the beginning, a real game changer and almost like a miracle that we need to help these patients. And the beauty is that the company being in Israel is closer to God. So I think we have a very good chance that this will actually work. Now, my question to the PI, Dr. Michael Conte, is what is your take-home point from this BGC 101 trial for the vascular community today? Because people are are listening to this.
Well, I think as Dr. Powell mentioned, there's been work going on in cell and gene therapy for over 20 years, and there's been, some failures in the space, but the science keeps moving on. And I think what we can share with the vascular community today is that this particular cell therapy product shows some real promise. And it's based on continuing to iterate over time what might be the optimal types of cells. These are cells that are designed to be regenerative as well as anti-inflammatory. So I think it's exciting that the field keeps iterating forward, and we'll look forward to being able to do a larger scale trial to really test this out.
Great. Dr. Powell, any final comments?
No, I think Mike, I think said it really nicely. This is it's an innovative therapy, and the phase 2 trial results are quite exciting. And we just need to, see if it's borne out in a pivotal phase 3.
Dr. Mills?
No, I agree. I think the potential is there, not just to treat no option patients, but if we can validate these results, we have a subset of patients with CLTI that could be helped without a more invasive procedure. And that would be a huge aid for some of these increasingly frail patients that have wounds that won't heal. It would be nice to have something you could do in the office and not have to bring them to the OBL or to the hospital for
Good
something
point.
more invasive.
Great point. Well, with that, I think we finalize this session on Biogen Cell, and we really hope that this works very well because the amputation rate continues to challenge us. So we need to help these people in trying to save their limbs because they do much better in terms of survival, quality of life, and it's a product that we very much needed. Thank you very much.